The first antibiotic that was really shown to be very, very helpful was to be given daily doses of an antibiotic called trimethoprim sulfamethoxazole. Its regular brand name is Bactrim or Septra. It may be called cotrimazole in other countries. And it has a couple of important features. Number one, it doesn't seem to affect very much the commensals in somebody's body. So it doesn't alter your normal ecology in your gut very much. And so that's a great antibiotic not to affect your body too much. But the other thing is that it just happens to have antibacterial properties against most of the key organisms that you want to protect CGD patients from. Staph, this Burkholderia I talked about, Serratia, even Nocardia. And there are others as well that seem to be sensitive to this. It's not perfect. You can think of it as by taking it every day, it erects a modest-sized fence. Organisms can still jump that fence, but it's enough to keep them out more often than not. So it reduces the frequency of infections with those diseases. I also get the question from a patient when they do get an infection, wait a minute, my infection seems to be sensitive to Bactrim, but I've been very good about taking it. Well, it's a fence. It's not a 100-foot high wall. It's more like a 4-foot wall, and sometimes things can jump over it. Depends on your exposure. So the second leg of the prophylaxis that we realize that CGD patients need is something to reduce the frequency of fungal infections. It's important to note that in other kinds of immune deficiencies, where there's abnormalities of T cells, everybody thinks of Candida as the major fungus, that is the thing, something that causes thrush and so on. Interestingly, Candida albicans, which is so problematic in other kinds of immune deficiencies, isn't a particular problem in CGD. And that's why the antifungals that people often use to prevent Candida infections don't do the job for CGD. We have found now that the azole, the broad spectrum azole antifungals are very important for this. And the first one that was studied was an antifungal called itraconazole, and it was shown to reduce the frequency of fungal infections in CGD patients. And I would say still the majority of CGD patients are on itraconazole. More recently, at many centers and here at the NIH, we've begun to instead replace this with oral posaconazole, which has a little broader and more potent activity. And we've been using that in modest dosing, not in the treatment level dosing, as prophylaxis. And, you know, I might have other experts in the field who agree or disagree with me, but we tend to use now posaconazole in most of our CGD patients going forward. There is another agent that's out there called voriconazole, which is very potent and is in the same class as posaconazole. The problem is that voriconazole, while it's a great drug to use in the hospital for certain kinds of infections, is a very strong skin sensitizer. And there's a subset of patients who may get rather terrible sun sensitization and burns. And when it's used long-term, year in and year out, we've even seen reported potential skin cancers from that kind of sun sensitization. Now, I don't want to scare people away from voriconazole used in the hospital because the fluorescent bulbs over your hospital bed aren't going to cause problems. But you don't want to be taking voriconazole and get out there in the sunshine. So at this point, I get to the third leg of this sturdy stool that needs to stand and needs all three legs to do the job right. And the third leg is that we have found that recombinant gamma interferon, a kind of immune hormone, can reduce the frequency of infections in CGD patients. We believe that the way it works is that it's one of these alarm hormones in the immune system. You get an infection, your level of gamma interferon goes up. It's one of the things that makes you feel, have malaise and tired and so on. So that's the good and bad news about this leg of the prophylaxis. It keeps your body on steady alert. It's administered 3 times a week, and we believe it does reduce the frequency of infection, particularly when used in combination with the two, the antifungal and the antibacterial prophylaxis.